Hello everyone, welcome to Medigec. Today we are going to discuss about immunothrombocytopenic purpura. This is also known as idiopathic thrombocytopenic purpura. This is an autoimmune pathology characterized by a low platelet count, purpura, and hemorrhagic episodes caused by antiplatelet autoantibodies. We will discuss ITP in 4 different parts, that is, clinical features, pathophysiology, investigations, treatment. First, we will start with clinical features. There are mainly 2 clinical features, and they are 1. Purpuric rash in the body. 2. Gum bleeding. These are purpuric rashes on skin. This is gum bleeding seen in ITP. Now come to the pathophysiology of ITP. Platelets has his own glycoprotein complexes like alpha-11-BB3 and GPLB. Antibodies are formed against this platelet glycoprotein complexes. Now this antibody starts to bind with the surface of the platelet. Through this process, the platelet becomes antibody-coated platelet. Now it's time for entry of splenic macrophages. These macrophages has Fc receptors. Now these Fc receptors finds and recognize the antibody-coated platelet. Then the macrophage attacks the antibody-coated platelet. And finally it destroys and digests the platelet. This is how platelet count starts to decrease and causes thrombocytopenia. Now come to investigations part. Number 1 is complete blood count. Here we can see severe thrombocytopenia, platelet count less than 20, 10 to the power 9 per liter, and hemoglobin will be decreased. Number 2 is bone marrow examination. Here we can see normal granulocytes and erythrocytes, but increased numbers of megakaryocytes. Now come to the treatment part. Education and counseling of the family. Patients should be early conscious about the symptoms where it is mild, moderate. Intravenous immunoglobulin, IVIG, this is given at a dose of 0.8 to 1.0 gram per kg per day for 1 to 2 days. Intravenous anti-D therapy. Corticosteroid like prednisolone is given.